be done and what is not to be done. So, Foxy has made this respectful abortion care program, and we've had wonderful people amongst us who have gone in and got trained. And today we have some really good teachers with us, like Dr. Revati Janagram ma'am is there with us, and Dr. Nancy Tanu. I'm sure actually all of you must have read her chronicles. She is not only a good doctor, she is also very good at writing and expressing herself. Beautiful lines, ma'am. Actually, I really enjoy reading your words and your posts in the Foxy groups. And welcome you. We would like to hear all about MTP from you today. And I would also like to welcome all the other speakers. All of them are excellent and they've been trained. One of them is our own Dr. Prema Priya. She's a very enthusiastic lady, and she comes up for all programs, and she gives her 100%. I welcome all of you, and I think the rest of the program we can take on from there. Dr. Saravana Kumar, can you put up their CVs? So Dr. Nancy Tanu, she is the president, Erode Obstetrics and Gynecological Society. She did her MBBS from Tirunelveli Medical College and DGO from Government Stanley Medical College, Chennai. And she worked as government doctor for 3 decades. She retired as Deputy Director of Family Welfare, Erode, in March 2018. Now she is working as RMO, Erode Emergency Care Hospital, Tertiary Referral Center at Erode. She also does private practice and Ratnam Maternity Clinic. She has had a lot of important posts in the past president of Erode IMA, past president of Government Doctors Association, Erode District, past convener and chairman of Women's Doctor Wing, IMA State Branch for 2 tenures, and she's a past chairman, Fine Arts Committee, IMA State Branch for 2 tenures, and past chairman of Mission Pink Health, IMA State Branch, and she is the recipient of so many awards, like IMA State Awards, Best President Award from IMA TNSB as EAMA President in 2012, Appreciation Award for Facebook Activities in 2013. Wow, ma'am, you've been really active. And she's got the Best Doctor Award for Women's Wing Activities, Fine Arts Activities during IMA State Conferences in 2014, 15, 16, and 18. With that, I welcome Dr. Nancy Tanu.
Thank you, ma'am, for the introduction. Can I have the slides, please? Thank you, Dr. Vidya, ma'am, for a nice introduction. Thank you, Dr. Saravana Kumar, for giving me this opportunity. Though it's a combined effort of Erode and Salem, it was entirely done by your society, and thank you for this wonderful arrangements. We are having knowledge about MTP, previously what we are doing, but a lot of amendments have come. But many of our colleagues didn't know it yet. So we are doing it in like a previous one only. So Foxy has taken it as a initiative in the name of respectful abortion care and to teach our members to follow the recent amendments also. Next. So what is the objective of this training? What are the new laws? What are all the changes in the rules? Next. So unsafe abortions in India leads to the higher maternal mortality. So 80% of the maternal deaths per year due to the largest MMR. 2 out of 3 of the abortions performed are unsafe. It is in the untrained persons in outside a doctor's consultation place. Nearly half of the pregnancy-related deaths are in the age group below the almost in the adolescent group is increasing nowadays. Next. So when the abortion is considered safe, as we know, it should be done by the appropriate method by a trained person. Wherever it is other than these 2 things, it is always unsafe. In the hands of an untrained boy or a private Siddha doctor or a staff nurse or wherever it's happening, it will be unsafe, and the trained person should conduct the abortion is a mandatory thing for us. Medical Pregnancy MTP Act 2001 has come up with a lot of amendments. It is initiated by the law also. So we can confidently use the amendments in our practice. So the salient features of 2021. We know the previous act, it needs opinion of one provider up to 12 weeks and two providers 12 to 20 weeks. But latest amendments, one registered medical practitioner, we'll call it as RMP, for termination up to 20 weeks. Up to 20 weeks, we will call for one more person and get opinion from her, and we will be waiting for so many days. Now, up to 20 weeks, one registered medical practitioner will do the MTP. After 20 to 24 weeks, we will get the opinion of the next person. Next. So previously, MTP permissible beyond 20 weeks only when it is due to the maternal cause. They don't mind about the fetal cause also. Now it is extended up to 20 to 24 weeks for vulnerable women and also for the fetal causes. So both. Previously only maternal causes we will go beyond 20 weeks. Now maternal as well as fetal causes can be considered for 2021 amendment cases. Next. So this is the thing. Upper age limit does not apply in case of pregnancy if the substantial fetal abnormalities diagnosed by a medical board. So up to 24 weeks, we can have the amendment for the second trimester abortion. But if it is with the congenital anomaly baby, with the consensus of the medical board, the upper limit can be even extended up to 27, 28 weeks also. So increase in access to the safe legal abortion services, who often seek service late beyond age limit of termination of pregnancy with substantial fetal anomalies diagnosed late, thus reducing unsafe abortions and court cases. Because after 24 weeks, even I am having a patient with an unossified nasal bone for up to, she has been going between doctor to doctor from 12 weeks up to 24 weeks. He landed with me by 24th week. I don't know whether to continue it or whether I can, now only I am reading that with the consensus of the medical board, we can do termination for her. Even myself don't know, even reading before that, because we will be knowing one person, one medical practitioner, two medical practitioner, 20 weeks, 24 weeks only, we will be knowing it. But even after 24 weeks, if the fetal anomaly is not compatible with the life, we can go for an MTP with the consensus of the medical board. It's a good thing because so many patients will land up at the age of 26 weeks, even with the anencefali at this time. We don't know what to do. So it's a very good amendment. Next. So failure of contraceptive may applicable only to married. Now the living together, unmarried couples and the social things are going in a different way. We can't ask for a married or unmarried. If she is a major, we can give a respectful abortion care to the person. So increase access to safe and legal abortion for any woman irrespective of marriages, especially with upcoming changes in legal age of marriage. Our marriage age is coming up to 19 years. So after that, we can do MTP services to any person. Don't ask for the marital status. Next. So MTP Act 2003 mentioned that information should not be disclosed except under authority law. Now, name and other particulars of a woman whose pregnancy has been terminated shall not be to reveal except to a person authorized by any law. For the time being, the post. It is like an unmarried girl is coming for MTP, whom to tell? If she is coming with the husband, we can tell, because the act is not asking us to give particulars to a person or not. If at all any complications comes, to whom we can land. For a person coming for an MTP, unmarried person, to whom we can tell. So if she is comfortable with a partner, whether a mother or a friend or a boyfriend or whatever, whichever is acceptable by the law, we can reveal the facts to that person. In that case, we can't hide the fact from them, because we also should make us safe Because when we are doing a MTP, if she is going for a PPH and mortality comes, whom do we stand? So in that case, we must inform at least any one of the person reliable to accompany, and we must disclose the fact to that person. So increase in privacy and confidentiality of the abortion seekers, increase demand, but no need to safeguard rights and dignity of women, and provide respectful bias-free services, including counseling and contraception. Next. So MTP amendment salient features prioritizes confidentiality as well as safety. So when we are going for confidentiality, if we are not telling to anyone and only the person coming for MTP is knowing, the safety is breached. So we must consider to whom we have to reveal the fact also. Name and other particulars of any women seeking abortion to be confidential except to a person authorized in any law for the time being imposed. The ground failure of contraceptive has been extended to women and her partner. So rules define special or vulnerable category of women eligible for extended gestational period of termination of pregnancy from 20 to 24 weeks. Then the norms for the registered medical practitioner whose opinion is required for termination of pregnancy at different gestational age. Up to 20 weeks, one person will do. After 20 weeks, two persons. After 24, if the MTP is needed by the consensus of the medical board. The powers and functions of the medical boards formed for each state and mandated to provide timely evidence-based decisions. So, women with the who are all the persons we can tell, we can reveal the fact. It's given by the law. With the physical disabilities, change of marital status during the ongoing pregnancy, she has every right to go for MTP, but we must find a person to tell it. Women in pregnancy, in humanitarian settings, disaster, emergency situations as declared by government, mentally ill women, including mental retardation, minors, fetal malformation that has substantial risk of being incompatible with life, or if the child was born, it would suffer from physical or mental abnormality throughout his lifetime, and it will be handicapped. Survivors of sexual assault, rape, incest. So these are all the amendments that is given in 2021. Next. So RMP, as we know, previously RMP's category was different. They will have 25 cases or something. Now they have reformed the RMP stature. One RMP opinion up to 20 weeks, two RMP 20 to 24, medical for beyond 24. It's coming. So who are all RMPs? Medical practitioner assisted in 25 cases of MTP, or at least 5 done independently. He will be considered an MBBS who has assisted 25 cases and 5 MTPs individually, or who has completed 6 months of house agency in OG, or who holds a postgraduate or diploma. It's a common thing. Medical practitioner who has experienced at least 1 year in a obstetric nursing home. These are all considered as RMPs. This is applicable for the 20 weeks, 24 weeks and beyond 24 weeks. RMP, yes, next. So under amended rules, an additional category of a provider has been added. For termination up to 9 weeks, we are going for medical methods of abortion. In that case, RMP with obstetric experience at any hospital for 3 months. Training with the performance of 10 cases of MTP by MMA, medical method of abortion, under the supervision of a previously trained medical officer. Either the previous columns of that 3 categories, no, that RMP can help her for 10 cases in MMA. So they can be included in this modern amendment. Next. So the norms of the RMP whose opinion is required for termination of pregnancy at different gestational ages, already we have talked. Experience at any hospital, 3 months, 10 cases by MMA under supervision of an RMP, 6 months, assisted an RMP for 25 cases and 5 cases on their own. Postgraduate degree is a normal thing. 6 months of house agency, senior house agency in OG, 1 year in a private nursing home, OG nursing home. That is, one RMP is required category. Next. So, two RMPs, when we are considering two RMPs, both RMPs will be having these categories, that is 6 months house urgency or whether it comes. A practitioner assisted an RMP with 25 cases and 5 cases can be considered as the first RMP. Postgraduate degree is always there. 6 months house urgency is also there. 1 year in an OG nursing. So, but that the MMA giving doctor cannot be considered for this RMP of the second opinion. That below 9 months category, we are giving one category for RMP that is included in the amendment. That RMP cannot be considered for this 12 weeks category. That is only for the 9 weeks. Next. So, for the different gestational age, when it is coming to different gestational ages, the RMP's qualifications are still more scrutinized and concise. A practitioner holds postgraduate, all obstetricians, 6 months house urgency and 1 year practice in an OG. Not that who have conducted 25 cases under an RMP or that 9 weeks category. Those people won't come in this category for two people's opinion or the consensus. Next. So, so next, 20 to 24 weeks. Beyond 24 weeks, a postgraduate obstetrician, 1 year obstetrics experience. In this, those who are conducting 25 cases under one RMP will not be included in these things. Actually, it is a board related thing. Always the board will be comprised of only postgraduate degree or diploma in obstetrics will be there. So these conditions won't come there. Actually, the 1 year of practice of obstetrics and gynecology also won't come in a board because all the boards are formed in medical colleges. There, no trained persons, only qualified persons will be in the board. So no question of this two also. Only a postgraduate degree or diploma holder will come for the board. Opinion of the medical board is required for the termination when advised by medical board. It is carried out with all safety precautions along with appropriate counseling and in an approved place. It's very mandatory. Next. So, composition of medical board, any gynecologist, one pediatrician and radiologist. It's a standard procedure. Next. So, powers of the medical board is very much to allow or deny termination of pregnancy beyond 24 weeks of gestation period only after due consideration and ensuring that the procedure will be safe for the woman at that gestation age and whether the fetal malformation has substantial risk of it being incompatible with the life or if the child when born would suffer from such a physical or mental abnormalities or handicap. Even before, after 24 weeks, the board can give consensus. Even then, the experts will outweigh whether that mother can go for that MTP beyond 24 weeks, considering all these things. They have every right to refuse also. Co-opt other specialties in any additional investigations if required for deciding the termination of pregnancy. Maybe if she is having some metabolic problems or some other problem, they can co-opt other specialists also. FOXI with ministry guidance and who support as part of RAC can operationalize and host medical code information on website. Next. So rules, the functions of the medical board to examine the woman and her reports. Then provide an opinion of the medical form in Form D with regard to the termination or rejection of the request within 3 days. Because previously, after 20 weeks, we are not able to do MTPs and we are referring the patients to medical boards. But by that time, the patient contacted the lawyer or somebody and went to the medical board and they are returning. The pregnancy will be beyond 28 weeks and it will become a normal delivery period, viable fetus. So they have fixed norms that rejection or permission should be given within 3 days of receiving the request. It's a very good thing for us. To ensure that the termination procedure, when advised by the board, should be done with all safety precautions with a trained person in an approved place. So, It is important role to play ensuring there are functional medical board in every state as it is stated in MTP Amendment 2021. Next. So, thank you for giving me this opportunity. Though we have done MTP with so many pitfalls and very difficulties, when the anencephaly is coming after 20 weeks, we are not able to do it. We will send them to the board. By that time, the patient will come by 28 weeks. We don't know whether to do a LSCS or terminator by normal delivery. So many issues. Now, the 20 to 24 weeks with the 2 medical practitioners consent is a very good boon for us, because mainly for the congenital anomalies babies. We are facing a lot of problems in the past between 20 to 24 weeks. They will come only by 20 weeks plus 1 day. So we will be in a soup that we can't do anything. Now up to 24 weeks means we will be able to give good results to the pregnant mothers, not to have an anomalous baby or something. So we must thank the government for giving this amendment for the better practice of doctors. Thereby they will come to a doctor. They won't go to the private practitioner or an untrained boy or a person who is doing some unethical abortions. They will definitely come to a medical practitioner. Thereby we will reduce the maternal mortality still more in future. Thank you all for the patient hearing. Thank you, ma'am. Thank you, sir.
Thank you very much, Dr. Nancy. That was a wonderful presentation. You have really enlightened us about the latest developments. And actually, this act is a boon for all of us, because I think it has strengthened our hands and probably reduced our dilemmas. Now, the only thing is there are, I think, a couple of things like unmarried girls. So when unmarried girls come alone, what do you do? That is one thing. Even if they come requesting for MMA, like they come alone, can you do it? That's
no,
one thing. You can't do it, isn't it?
No, we must give, I think when law gives permission, we must, because when you are giving an MMA, if she goes for profuse bleeding, she won't tell it to anybody. That maternal, what is the cause of amendments will be lost if we are not telling to anybody. So for unmarried adolescent girls, don't ever do MMA without revealing the fact to any one of the person accompanying her or a legal person. It should be a mandatory. It should be given in the amendment also, ma'am, because a lot of +2 girls are coming with pregnancy during the lockdown. So many girls, but Dr. Ajay Mane and Girish Mane have told that you can do with the parents' consent, but you must inform it to the police. But the confidentiality is breached. In that case, whether we can take the thing to the police station and tampering the girl's future is also a dilemma.
Yes. So, and another thing is when they come alone, because nowadays they are very smart. They are very smart. They just come and they say that I want it. So there are girls like this nowadays. So that becomes a real difficulty. Like you have to bring somebody and all that. So that is one thing that we should not do it alone. And as far as the abnormalities are concerned, has a medical board been established everywhere?
In Salem, we are sending our patients there only. Salem is having a very good medical board, but the time delay was a lot. Now they have given a 3 days time, so we can send patients. We have to have a rapport with the medical college team, and we must make it feasible for the patients also.
And for the information of all the people who are listening here, can you please tell us how to apply for the medical board? Where should they go when a practitioner gets a patient who's had an anomaly, let us say at 22 weeks, which is not compatible with life? So where should they go and apply? Is there a form for it? How do they do that? Whom should they inform?
Usually I will call up this JD madam and tell that there is a patient.
Yes, we are doing that. No. Is there anything like, is there any place like, there is a medical board to whom you have to apply something like that? Is there anything?
No. We are sending the patient through our DD family helper, ma'am. We are having an RCH, maternal child health officer for any district. We will tell them that she is having an anomalous baby. She has to be referred to the board, and she will tell it to the DD family helper. They will make things for us in our district. So we are having some feasibility, but we must have a standard referral form for that, and we must work for it.
I think that is one thing which needs to be done, because what happens is when you refer a patient like this to the JD welfare, JD family welfare, what will happen is usually normally we tell them you go there. So what happens is then the patient actually goes to the GH and she has to get a termination there. So they don't come back to us. So that is one thing. So whether the law says that it should be only in the government sector, it should be done in the private sector, or if we can do it, then in that case there should be a procedure. I think we should evolve that procedure so that we apply to the board, and then the board certifies and sends the patient back to us. So is there facility for that? That's what I would like to ask.
In that special cases, we must do it in a theater where an IC facility is there. When it is coming for a MTP after 24 weeks and we are sending it to a board and we are doing it, we must take utmost care that no mother should get a PPH or some complication and they should not land up with the mortality. So in that case, we can fight for that referral back. So in that case, even a private practitioner, a small setup, they can have a MOU with the nearest tertiary care center where they can do a special MTPs. And my suggestion is like that, because at least one ICU care should be there, or a MOU with the tertiary care. Then if any problem comes, they are having an MOU, because when on maternal mortality meeting, they will be asking if it is a PPH, have you got an MOU with the tertiary care when an ICU or ventilator is there? So these things also we have to have in mind, ma'am.
Dr. Sarwan, I think there are a lot of questions there. Can you please read them out? There are a lot of questions on the chat box. Somebody was asking, is an RCH ID essential for doing an MTP?
In family welfare department, they are telling, ma'am, but for 7 weeks and all, we were not able to get RCH ID because the nurses are not giving RCH ID up to 12 weeks. They ask the patient to come for 2 or 3 times. Only after 12 weeks only, they are making some issues not to give the RCH ID up to 12 weeks. So we have to have representation with the government also to give the RCH ID if the patient is positive.
And there was another question also there when regarding the RMPs who can do up to 9 weeks. You had said some of these RMPs can do up to 9 weeks, right? So you were talking about MMA. So somebody had asked a question whether only MMA is permitted for all these RMPs up to 9 weeks, or we can do a DNC also. That was another question.
No, ma'am. They have to undergo MTP training at the reputed thing. For an RMP is an MBBS, if he is having an MOU with the nearest obstetric nursing home, they can prescribe MMA. It is in our MTP Act. An RMP up to 9 weeks, they can give MMA provided they are having an MOU with the nearest obstetric nursing home. It should be displayed in their consultation room. Only for MMA. For MTP, they must undergo all that category, that training in that obstetric nursing home for 6 months or 25 cases, 3 cases. All these things they have to undergo for doing any instrumental MTP. Only medical abortion they can do.
I think Ajay sir has joined in between, and it's written good to see the participation in such a large numbers. Best wishes to all the office bearers and members. Thank you, sir. Thank you for your kind message. And
thank you, sir. Thank you, Ajay,
so much, everyone. It's lovely to be here. And it is so encouraging to see everybody here on a Sunday morning, and participating so very actively. And Sarvanana, you have done a fantastic job along with your team to have so many members here. And a huge congratulations to everybody in the faculty for taking it so very well. Nancy, you did a very good job. I must really applaud you. Because
thank you, sir. Thank you, sir.
And the further speakers to come in. I just wanted to, I've overheard all the discussion that has been going on regarding unmarried or married or, smart girls coming in 10+2 and all of that. See, important thing for us to note here is service cannot be denied. Okay. Having said that, please ensure you protect yourself in every which way with the documentation that needs to be put in place. Thirdly, make sure if the girl is underage, POXO reporting and POXO documentation has to be in place for your own protection and all of that. Fourthly, all confidentiality and documentation related to that confidentiality to be kept for 5 years or whatever the state has prescribed needs to be in place. If the person is underage, POXO reporting, but services can be provided by taking consent from an accompanying adult whose Aadhaar card is something you can take a copy of and keep it as a proof for yourself, because at the end of the day, you also need to protect yourself in every which way. So report, document, provide the services. And if the woman or the unmarried girl is there and who is above 18, in such a case, you need not get a consent from anybody else. The woman or the girl itself can give a consent because she is above 18 and it is prescribed by the law. Now, having said that, there is a gray area. The parents or the family or somebody else may come and do a dharna in front of your clinic that how could you do this without our knowledge or this thing. Now, in all such cases, make sure you have the documentation in place. And for all such things, you will have to alert, the concerned woman whom you have given these services that, this might come up. And therefore, while we will not be revealing the record, we will be maintaining confidentiality, but it may make sense for you to be proactive and make sure whoever is concerned with you is kept in the loop. Do not do this in isolation, because suppose during the entire procedure, something goes wrong.
Yes, sir.
Okay. Then whom do you contact? Then whom do you reach out to? It's the woman who has just come alone. When I say woman, I mean the girl who is 18 plus and unmarried. Whom do we? So, it may make prudent for your own this thing that you bring in that. And I'm sure with your kind of, cajoling and counseling, the unmarried girl who is above 18 should come around and get something, and we have been asked this question in other forums also. What if the boyfriend is coming with her? So be it, so long as the boyfriend is above 18 and gives the consent and stays for the duration and is, ready for any kind of consequences thereafter as well. Many times they just give the consent and run away, So bottom line is protect yourself. Ensure all documentation is done. Whatever POXO reporting has to be done, needs to be done. Confidentiality needs to be maintained. Services should not be denied. The law, the new amendment is all in your favor and also the woman's favor to make an informed choice. I hope that clarifies everything.
Thank you, sir.
Thank you, sir.
Thank you for the clarification, sir.
Thank you, sir. I think I'll.
Sir, the only problem is when we are reporting the POXO, the confidentiality, when it goes to the law, the parents, a parent or the accompanying person or the patient feels very bad. That's the thing we are having a dilemma in reporting to the POXO, sir. Yeah,
I know that is a challenge, but ideally, if even at that level, it should not go out because your documentation goes in a sealed envelope to them. And if the police is doing it, there's not much you can do, but while giving the document or handing it over, you can make sure you are re-emphasizing this fact that as per the law, this should not be disclosed and it should be only within that closed circuit that one needs to rotate around, So I know a lot of gray areas there and a lot of, ifs and buts keep happening, but we have to work with the system with whatever best possible we can do and make sure we protect the woman and the informed choice that she has made, provided she is above 18 and able to make that informed choice.
We have to protect the woman as well as we have to save our skin also.
Sorry, yes, absolutely. Absolutely. You have to, because at the end of the day, you are the service provider and you shouldn't fall into a situation which is going to lead to your complication for your own life. And we see that happening dime a dozen now. The recent cases of, you have been hearing about it of Dr. Archana as well. That's a different matter altogether. But, you some point in time in your life, you would have faced it, these kind of, situations. So protect yourself. That is what the first thing that I said. And make sure documentation is there as per the requirement of the law and provide the services, whatever is required. Yeah.
Sir, there are some more questions over there. So MMA, providing MMA is only up to 7 weeks or is it up to 9 weeks?
Now, I would request one of the technical peoples to reply this, because, you know, that would be a zone for somebody who has got that kind of experience. So I would request Nancy or somebody to please reply that, or Sarvana himself to reply that, please.
See, up to 7 weeks,
So
the
only we
success
are doing
rate is
MMA.
quite high.
Yeah.
Whereas up to 9 weeks, the success rate may be a little less. Say, for example, if it is 98,
Incomplete abortion.
90%.
Yes,
The requirement of subsequent DNC will be a little higher up to 9 weeks, which will be lesser with 7 weeks. So we can go for both.
So we are
Usually we will
legally
counsel
allowed.
the patient
No, that's
and
what
then
I
we
want to
give
know.
up to 9
Legally, are
weeks.
we allowed?
Sir, one more question. If any of the alternate medicine persons can give MMA, sir, many of the Siddha doctors and the Unani people are giving MMA, and pharmacists are issuing things to the patients. MMA drugs given
over,
by
over the counter, it is restricted.
Yes.
Medical shop, they are not giving.
no,
No,
ma'am.
madam, that's what
They are
Dr.
giving.
Vijay
That
has
is the
given raised
problem.
this question.
In
That's
Madurai,
the
they are
problem.
not
We are
giving.
getting PPH in casualties only incomplete abortion because of the MMA prescribed by some other alternate medicine persons. Is there any class to restrict them or to prevent them or change them?
There are a lot of things which are happening, and one of the primary reason for this under the counter, over the counter, on the sly, and, you know, all this is happening because of the stigma associated with abortion and things related to abortion. And, you know, that stigma is coming from the fact of what the policies and the laws were in the past, and also our own stigmas, you know. Because if an unmarried girl comes to us who is 18 and above, and then we start suddenly thinking, oh, so you're, you know, you want an abortion, so what are you doing? You know, it automatically comes out because of our own upbringing and our own beliefs and all of that which is coming out. Therefore, this entire module that we are talking about, the saver kit, the pre-counseling, the counseling, and talking about this entire thing as abortion, not as abortion. It is, you know, respectful abortion care is what we are talking. So we are going to address those bits also over here. So there's very little that we can do in terms of making sure, you know, the pharmacists are not giving such drugs and all of that, but still it will happen. The patient will land up at your table for some point or other. We are hopeful with this RAC program as we go along, and more amount of information and noise level being generated, women will be more confident to come to a registered provider, an experienced provider, to be able to give that service without having the fear of, you know, being stigmatized or fear of not getting the service is what is going to happen. So we are hopeful that will happen. Till such time, we will have to keep dealing with something like this going forward.
There are some tricky situations also. Yesterday I had a patient from Qatar. She is my own patient. She just missed her period. They will not allow any method of MTP there. So over phone, she's asking me to prescribe medical method, and her relative will come and collect from me, and then they are going to use it. Is it permissible?
I mean, at the end of the day, you have to still document it that this is what you have done.
Yes.
And they need to document it somewhere so that it has that they have requested for something like this. And yes, service cannot be denied if it is being asked for, and it is in your collective opinion and your experiential learning, you feel that is the right way to do it, and by all means go ahead and do it.
Sir, denial is mostly in the government setup, sir. After 7 weeks, they won't do. If the HB is a 9 gram, they won't do. So the denial at government setup for the poor persons, they will land up with the alternate medicine or that person. That's the problem. Private practitioners, we won't deny any abortion. We will give the respectful abortion to the patient. But in government setup, the denial is more because of the overload. Those patients are going to the untrained doys because they are not affordable. So you must make a rapport with the government and to tell them not to deny abortion, because the maternal mortality coming from the government setup denials only. I have seen it in the past.
Actually, I thought of inviting DD Madam Family Welfare to this meeting. I somehow was out of my mind because
Me too also.
yeah.
I forgot.
I should have asked them to come for this meeting today.
We will tell them.
Okay. So can we move on to the next session?
Yes, sir.
I will call upon the next speaker, Dr. Premapriya.
Sir.
Dr. Premapriya is she's an associate professor in Vinayaka Mission's Kripanandamari Medical College. She's got she's well known to me. She's my colleague in the college. Her awards were the best poster award for Eva Foxy South Zone in Madurai, 2016, Foxy Srimati Bhagavato Devi Yamuna Singh Prize for the best paper presentation in ACOG Bengaluru and training in endogynecology at GEM Hospital Coimbatore. Publication, she's got 12 publications in national and international journals, and she's presented several paper and posters in national and international journal conferences, and her area of interest is adolescent gynecology. Over to you, madam.
Thank you, sir. Thank you for your kind introduction, sir. I'll just share the slides, sir. So can you sir, you're able to see the slides, sir?
I'm not able to see the slides.
1 second, sir. Sir, is it visible now, sir?
Yeah. Make it full screen.
Yes.
Click on the close button, madam.
1 second, sir.
Click on the close button, madam.
Okay, sir.
Click on this enable editing button, madam, which is there in the yellow line, right?
Which one, sir?
Enable editing, madam. The top, madam, top.
Yes, you're done.
Is it okay now, sir? Shall I start?
Yes,
Yes,
please.
ma'am.
Yes, you can start.
So today I'm going to talk about safe abortion, updates in technology. The slides are not moving, sir.
You have to click on this enable editing, madam. First, go back and click on this enable editing. Then only the slides will move.
Yeah.
Just go back, ma'am.
Just exit
Exit.
application.
Yes. Yes, sir. Is it moving now? Sir, only one slide I can move, sir.
Shall I download and make it?
Yes, sir. Yes, sir.
No,
Sure, sir.
just do it.
No, what you have to do is just close the sharing.
Stop share. Okay, sir.
Stop sharing. Now
Yes, sir.
reshare.
Share screen. Okay,
Share.
sir. Module 2.
Yeah, share screen.
Okay, sir.
Now, when you share the screen on top below the red line, you see enable editing.
Yes, sir.
Click enable editing.
Shall I share? Shall I share?
Yes, sir.
Okay.
So now I clicked, I think.
Okay.
So.
Go to full screen. Bottom. Full
Bottom.
screen. Yeah. Now try.
Yes, sir. Yes, sir. Yes, sir. Fine, sir. So today I'm going to talk about safe abortion, the updates in technology. So overview, we're going to talk about existing guidelines. What are the pre-abortion assessment? What are the medical methods and surgical methods of abortion available? So these are the WHO global guidelines on safe abortion. And this is a roadmap to WHO safe abortion guidelines from 2012 to 2019. And further historic change has occurred in 2021. That is, the laws are changed in 25th March 2021, and the rules are changed from 24th September 2021. All guidelines have 3 areas in the management of abortion safely. This includes pre-abortion care, abortion care methods, aftercare, and follow-up, which includes post-abortion contraception and counseling. So initially, detailed medical history should be taken, followed by physical examination, and if necessary, lab investigations. And further, shared decision making should be taken with the patient after discussing about the available methods of abortion and the contraceptive options available. Coming to the pre-abortion assessment and counseling. So these are the components of pre-abortion assessment for women seeking first trimester abortions. This includes detailed history taking, general physical and pelvic examination, lab and other investigations if necessary, and shared decision making after informing about the abortion procedures, contraception options available, and detailed counseling. And the gestational age determination is by last menstrual period or by physical examination. As we know, after 4 weeks of gestation, the uterus increases in size by approximately 1 centimeter per week. By 12 weeks, after 12 weeks, it rises out of the pelvis. And by 20 weeks, the symphysis fundal height in centimeters corresponds to the period of gestation in weeks. However, there's some limitation. The uterus is smaller than the expected date in case of the woman is not pregnant, inaccurate menstrual dating, or in case of ectopic pregnancy or spontaneous or missed abortions. In same, the uterus is larger than the expected date in case of inaccurate menstrual dating, multiple gestation, molar pregnancy, or uterine abnormalities such as fibroids. Coming to the pre-abortion investigations, routine lab test is not a prerequisite for abortion services. However, it can be done if necessary. If the pregnancy is unconfirmed, then the pregnancy test can be done. In case of suspected anemia, hemoglobin or hematocrit can be done. In case of Rh negative mother, Rh testing and other testing such as HIV testing, counseling, sexually transmitted infection screening can be done if necessary. Ultrasound is not necessary unless the diagnosis of pregnancy is uncertain or in case of suspected ectopic or missed abortion. Coming to the pre-abortion counseling, we must ask the woman about her thoughts about terminating pregnancy and what's the reason for terminating. We should inform her that early abortion is always safe and the importance about the trained provider for performing the procedure safely. And we should inform her about the available methods of abortion, the risk and warning signs associated with the abortion method. We must also ensure her that without contraception, she can get pregnant as soon as 14 days after an abortion. And regarding the resumption of normal activities, including the sexual intercourse and any other follow-up care. We should document the written informed consent and the decision to accept post-abortion contraception. And even if she's not willing for contraception, she should be provided with abortion services. She should not be denied about the abortion. So coming to the clinical management of abortion can less than 12 weeks globally, it is recommended to give misoprostol or misoprostol only and vacuum aspiration. More than 12 weeks, again, mifepristol, misoprostol combination or misoprostol only or dilatation and evacuation. However, globally, it is not recommended to perform dilatation and shock curettage. So, global recommendation about the medical method of abortion is up to 7 weeks, that is 49 days, mifepristol 200 mg orally, 24 to 48 hours later, misoprostol 800 mg sublingual, buccal, or oral or vaginal. In case of 7 to 9 weeks, you can give again mifepristol orally 200 mg and wait for 24 to 48 hours. And then we can give misoprostol 800 micrograms either sublingual, buccal, or vaginal. So methods of first trimester abortion, it can be medical methods or surgical methods. Medical method includes medical methods of abortion MMA. Surgical methods is manual or electronic vacuum aspiration. Coming to the mifepristone, it is an anti-progesterone. It inhibits the action of progesterone. It interferes with the continuation of pregnancy. Initial oral dose of mifepristone, that is 200 mg, followed by misoprostol, that is prostaglandin analog, is given. Misoprostol causes cervical softening, uterine contractions, and expulsion of the products of conception. The advantages of the tablet include it is safe, it is cheaply available, and it is stable at room temperature. Coming to the protocols, as we mentioned, the mifepristone 200 mg is given orally on the day 1, and at the same time, if the mother is Rh negative, anti-D 50 mg can be given. And this is a misoprostol day 3, that is 24 to 48 hours. Misoprostol should be given up to 7 weeks, either 400 microgram, 2 tablets of 200 microgram each can be given sublingual, buccal, vaginal, or oral. In case of 7 to 9 weeks, 800 microgram sublingual, buccal, and vaginal can be given. Along with this, in addition, analgesics, antiemetics can be given, and contraception can also be offered. And the woman is asked for follow-up on the day 15 to make sure and confirm that the abortion is complete, and offer contraception if not already done so. Coming to the routes of administration of the MMA drugs, it can be oral, buccal, sublingual, or vaginal. Oral pills are swallowed, and buccal, that is placed between the gums and the cheek, Sublingual, it is placed under the tongue. Vaginal, it is placed in the deeper fornices of the vagina. So orally, it is recommended up to 7 weeks, that is 49 days for first trimester abortions. Side effect includes diarrhea, nausea, fever, and chills. In buccal, fever and chills are more than the vaginal route. Sublingual route, the advantage is it is the fastest onset of action and has highest plasma concentration levels. In case of vaginal, the pills can be fragmented and it has lowest rate of side effects. So this is the buccal where it is placed between the gums and the cheek, and this is the sublingual, it is placed under the tongue. Coming to the WHO drugs, a dose schedule, that is, in case of induced abortion that is less than 12 weeks, it can be a combination regime, that is mifepristone 200 milligram orally and 24 to 48 hours later misoprostol 800 microgram buccal, sublingual or pervaginal route. Or alternate regimen is only misoprostol, that is without mifepristone we can give misoprostol 800 microgram buccal, pervaginal or sublingual. We must make sure that the woman is informed that vaginal bleeding will be there for 2 weeks and it is normal after medical abortion. In some cases, the bleeding can last even up to 45 days. Coming to the provision of medical methods of abortion, the services should be available at the primary care level with referral system in place for all required higher level care. As Nancy Madam mentioned, it can be given at the primary care level and there should be a proper referral system. So there are also additional services can be provided such as counseling and testing for sexually transmitted infections, abuse supportive services in case of unmarried girl, rape victim, etc. Provide psychological or social services or other specialist health or medical services. Provide iron tablets for anemia if needed. Provide medications for pain and provide emotional support if needed. Coming to the follow-up care, routine follow-up is not necessary following an uncomplicated medical abortion using the combination regime such as mifi and misoprostol. However, a routine follow-up visit is recommended only in case of medical abortion using misoprostol alone to assess the success of abortion. A follow-up visit that is 7 to 14 days after abortion may be provided to the woman to provide contraceptive counseling and services such as emotional support or address any other medical concerns. During the follow-up care, assess woman's recovery and ask for any signs or symptoms of ongoing pregnancy. Review the medical records and referral documents. Ask about any symptoms experienced since the procedure. Perform a focused physical examination for any complaints. Assess woman's fertility goals and need for contraceptive services if not provided earlier. Coming to the medical methods of abortion summary. So first day, that is detailed history, physical and pelvic examination should be performed. Confirm the eligibility, that is up to 49 days or 7 weeks of last menstrual period. Provide mifepristone 200 milligram orally, and if the woman is RH negative, then provide anti-D 50 micrograms. Tell the woman to return after 2 days, that is 24 to 48 hours, and give her the contact address and phone number of the facility or the center where she can go in case of any emergencies. Record her experience of any side effect on the MMA card. Almost 3% of women may expel completely with mifepristone alone, but however, the misoprostol schedule should be completed. During the second visit, that is 48 hours, that is day 3, the misoprostol 400 microgram sublingually, buccal or vaginal oral route should be given and observe her for 4 hours. Provide her analgesics such as brufen and give her contraceptive options such as condoms, hormonal methods, etc. Tell the woman that the mean period of bleeding is 8 to 13 days and the possible side effects includes nausea, vomiting, diarrhea, fever, dizziness, headache. Report in case of excessive bleeding or pain, abdomen and fever. If there is no bleeding 24 hours after misoprostol, then consider giving additional dose of misoprostol. Almost 75% of the women abort within 4 to 6 hours following misoprostol administration. During the follow-up day, that is day 15, perform pelvic examination to ensure that the abortion is complete and provide her contraceptive options such as condoms, hormonal methods, IUCDs or sterilization. Tell the woman about the immediate return to fertility, that is within 14 days of abortion, she can return to other fertility and report back if there are no periods within 6 weeks of completion of abortion process. Ultrasound is done if the abortion completion is not confirmed. Coming to the side effects and complications. Side effects includes pain, nausea, vomiting, diarrhea, and infections. For pain, Be non-judgmental, provide respectful verbal support, provide adequate counseling, and provide analgesics such as Brufen. If the pain is persistent, not responding to the drugs, then it needs evaluation for other causes such as ectopic pregnancy, infection, or incomplete abortion. For nausea, vomiting, and diarrhea, tell her that these are self-limiting and reassure. For infections, start antibiotics. If the abortion is incomplete or failure, if the medical methods is failure, then either repeat the medical methods of abortion or offer vacuum aspiration. If it is incomplete, the medical method is incomplete, then observe her unless heavy bleeding. If the bleeding is resolved and the uterus is normal size, that means the abortion is complete. If the bleeding is continuous, then either offer her repeat misoprostol or offer surgical methods of evacuation. So in case of excessive bleeding, that is bleeding more than her menstrual cycle, soaking 2 pads in 1 hour for 2 consecutive hours, then observe her. If bleeding decreases over the time, then provide her routine care, watch her vitals and bleeding PV. If it is stable, then she can go home. If it is not, then watch the vitals monitoring, do pelvic examination. If the products of conception are in the cervical canal, we can perform digital evacuation. If the woman is stable and bleeding reduces, then she can observe and we can monitor her. If the bleeding continues, then perform an ultrasound. If there are minimal decidual bits, then wait and watch. If there are products of conception and decidual bits suggesting it is an incomplete abortion, then either repeat the misoprostol or perform vacuum aspiration. In case of ongoing pregnancy, perform vacuum aspiration. So coming to the recording and reporting for medical methods of abortion. So it is mandatory to fill the following forms such as Form C consent form, Form 1 that is RMP opinion, monthly reporting form, and admission register for case records. In Salem, almost we are doing this monthly reporting form and consent form regularly and sending to the DD office. So coming to the methods of first trimester abortion, that is surgical methods. So it is vacuum aspiration is a recommended technique of surgical abortion for pregnancies up to 12 weeks. WHO recommends manual vacuum aspiration as the safest method. The procedure should not be routinely completed by sharp curettage. So sharp curettage is contraindicated. Coming to the vacuum aspiration methods, this is the manual vacuum aspirator. This is a handle aspirator used to generate vacuum. The aspirator is attached to the cannula of size 4 to 12 mm in diameter. This can be used in multiple settings, including those without electricity. A pass or easy grip cannula size corresponds with weeks of gestation. 8 mm cannula for 8 weeks and 10 mm cannula for 10 weeks. This is the electric vacuum aspirator where the electric pump is used to generate vacuum. It can accommodate cannula of manual vacuum aspiration with correct size tubing. So cervical priming can be done before the surgical abortion. In the first trimester, for the cervical priming, we can use either mifepristone orally, that is 200 mg, or misoprostol 400 microgram administered either sublingual or vaginal 2 to 3 hours prior to the procedure, or sometimes laminara can also be placed intracervically 6 to 24 hours prior to the procedure. Coming to the pain management, this is an important component of quality abortion care. It is mainly to reduce the pain and anxiety and make the woman feel comfortable. There are 2 components of pain management. It includes non-pharmacological and pharmacological. Non-pharmacological pain management includes providing psychological support, explaining each step to the woman in advance so that she is aware of the procedure, and performing the procedure gently and smoothly, and encouraging the woman to relax and breathe deeply. Pharmacological methods of pain management includes anxiolytics and general anesthesia sometimes, and for cervical dilatation, lignocaine or local anesthesia or analgesics such as Brufen can be used. For uterine cramps, again, analgesics can be used. All these has an effect of almost 4 to 6 hours, and the side effects includes dizziness, disorientation, and sometimes gastritis. Coming to the steps of manual vacuum aspiration. So initially, we have to prepare the instrument, we have to close the valve button and create the vacuum, and prepare the woman, ask the woman to empty her bladder, ensure pain control medication is given at the appropriate time. Then cervix should be antiseptic precaution should be done, administer paracervical block, dilate the cervix and insert the cannula. Withdraw the cannula 1 to 2 centimeter away from the fundus inside the uterine cavity. Rotate the cannula in 10 to 12 o'clock position with smooth, gentle motion. Release the vacuum button on the aspirator so that the contents are sucked. Signs that uterus is empty includes red or pink foam without the tissue passing through the cannula, gritty sensation over the surface of the uterus, cervix gripping over the cannula, or uterus contracting around the cannula. Then inspect the tissue. Then proceed with contraceptive measures such as IUCD insertion or sterilization. Then you should do the instrument should be soaked. Coming to the post-procedure care, monitor her for any complications and provide management as needed. She may leave the facility when she is stable and meets the criteria for discharge. Ensure that the woman has all necessary information and medications prior to leaving the facility. Document all outcomes of the treatment, including any adverse events in the facility register and client's record card. Coming to the aftercare, management of abortion complications such as incomplete abortion, infection, bleeding, ongoing pregnancy should be done. Provision of contraceptive information and offer contraceptive counseling and methods. Assessment of any other sexual and reproductive health needs that may require additional care. No routine follow-up is necessary unless misoprostol regimen alone is used. This is a new recommendation. Coming to the summary, India has made historic progress in improving access to safe abortion. Not much has changed in technological update in the last decade. As providers, it is up to us to ensure safety and quality, especially in the context of amended law. Along with safety, we also need to focus on respectful abortion services. Every client, whether public or private, has an opportunity to inform, educate, and equip with proper information on contraception and counseling. And I would like to say again that after the session, there will be a post-test and feedback form. Once if it is completed and submitted, we will receive the certificate. So in India, abortion is legal, and let us make it safe and respectful. Thank you. Thank you all for your patience listening.
Thank you, Dr. Priya. That was a wonderful explanation of the facts. The thing is, we have got some questions in the chat box also. Dr. Swarnam has told, can we insert IUCD at the end of 14 days after MMA if the abortion, or at the end of 40 days, or after MMA if the abortion is complete?
After the abortion is complete, we can insert, ma'am.
That is called PAUCD, post-abortal intrauterine contraceptive device. It is a type of contraceptive program approved by our government. Prema Priya, if you are priming the cervix with misoprostol,
okay, ma'am.
Applying a MMA cannula won't be that tight. The negative pressure won't be done properly. So usually I don't do priming with the misoprostol because that tightness is there. We will have the full evacuation with the MBA syringe. What's your experience in it?
Ma'am, either it can be mifepristone or misoprostol, ma'am. If the patient is under anesthesia, then it doesn't matter, I feel, ma'am.
Madam, if it is very loose, I will use the next cannula.
I would like to say something here.
Yes,
I mean, actually, we can always choose a bigger cannula to fit in, and I feel I always pre-medicate with misoprostol.
Yes,
because
sir,
even if it is under anesthesia, some of the services are difficult to dilate, and it is that pressure when you are somebody is trying to put a pressure only, you might go and perforate the uterus. So it is better, I think, to have a little, even if it is a little loose, it's still actually it's quite enough, I feel.
Yes.
I've never had an incomplete evacuation because of a loose.
Previous LSCS I will prime. Other normal second things I won't prime. That's why I'm asking. I will always do it under anesthesia.
So I think she has also answered another thing. Somebody had asked, 7 to 9 weeks. Can we do it up to 9 weeks? Actually, I think one of her slides, she has clearly written up to 9 weeks is there. So 800 Proctol up to 9 weeks, 7 to 9.
Yes, yeah.
Pretty much allowed. Somebody had asked a question.
Yes.
But one thing I want to tell, ma'am, if the weeks are advanced, then misoprostol dose should be reduced. Instead of 800, we can use 400 microgram every 4 hourly. Suppose we are performing at 13 weeks, 14 weeks, because it is extended up till 20 weeks. I want to include that also, ma'am.
Do you have any experience, misoprostol and mifeprostol on the same sitting?
No, ma'am, not on the same sitting, ma'am. Usually I wait for 24 to 48 hours, ma'am.
I have tried and it was successful also. Within 6 hours, it will be expelled. The patient is coming from far off, from a thing. They can't come for again and again. So in that case, sometimes we will have Mickey and Miso on the same.
From Suganti Velan, for giving medical methods of abortion less than 7 weeks, the clinic should have a license for termination of pregnancy or not. MMA or MMA.
If they are not having a license, they must have a MOU with the nearest obstetrician. That is a class in that RMP thing, no? Less than 9 weeks. If they are doing MMA, if their nursing home is not enrolled, they should have a MOU with the nearest obstetric nursing home displayed in the consultation room.
The woman should be given the contact details where she can go for referral in case of any emergencies after a MIFI or something, ma'am.
Yes. And that holds good for us also. Like suppose you are having only a consultation in some other place than your own nursing home. Then also you should display that you have, the MMA certificate, and that should be displayed in the clinic.
Thank you, ma'am. Thank you, sir, for the opportunity, ma'am.
A small thought, ma'am. This is regarding avoiding doing an ultrasound. I think I wasn't very convinced. When lawmakers they consider the entire India, the rural, urban, all the population, so they have to make generalized rules. But when it comes to places where people can afford, and I can remember a couple of situations, one where an ectopic was missed. Last Thursday, I had done a patient thought as ectopic. They given medical management, and I had did a lap ectopic surgery Thursday. Similarly, I remember a case where they had attempted a termination of pregnancy, suction evacuation was attempted. It was a cesarean scar pregnancy. So there was torrential bleed because the diagnosis was missed. So whenever possible, I would actually prefer, I would suggest doing an ultrasound.
Sir, we are doing it scan as a mandatory thing because we have to keep the scan also in that case sheet, because for family planning services, we must enclose the scan also. So all obstetricians are having a pre-scan for any type of, even for MMA, because MMA ectopic is very common. Failure of MMA drugs, when it's an ectopic, it will have tubal abortion or rupture. So we will tell the patient that if you are going for MMA, it's a mandatory thing to have scan.
But actually, ma'am, this is another point. I mean, even I wanted to discuss about. See, Tamil Nadu, I think it mandates that we need to have a scan in our register itself. Our register itself. But the Indian government, actually, the MTP laws are not mandating us to do the scan, prior scan. But at least one scan after before you discharge the patient is mandatory, I would feel.
Yes.
Somewhere you should do it, at least one scan.
Yes.
Because doing a scan at 37 days and 38 days, just 38, 37 days, actually nothing much is going to be seen. Even if you do a scan, you are not able to see any ectopic or anything at that point of time. But I think even at least before you discharge, you should do it.
And again, there are few more questions. 10 to 12 weeks, sometimes in cases of excessive bleeding due to atonicity, what Intrauterine to use? I think if you are complete, the thing is complete, and there's no products of conception, you can just put a misoprostol.
Misoprostol. Yes, sir.
RPOC post-abortion, is it necessary we should go in for a check curettage, or can we go with a vaginal misoprostol, madam? What's the cutoff ET we can wait and watch? Anything more than 1 centimeter, you just do another evacuation, or you can put a.
The bleeding is not exaggerated. We can assess and wait. The bleeding will be the thing.
Okay.
I think it is also more than 0.5, I think, because I saw it somewhere.
How much, ma'am?
1.5, more than 1.5.
Oh, more than 5.
Less than that, you can just give misoprostol and wait.
Okay, I think we can move on to the next session. I will call upon the next speaker, Dr. Vanitha Sri. I'll share her CV slide.
She is our joint secretary.
Okay, and Dr. Vanitha Sri is the joint secretary of Pregnancies Obstetrics and Gynecological Society. She is a UG from Coimbatore Medical College, PG from Tirunelveli Medical College, and she's a master trainer for RAC, and she's done presentations at states and national conferences as a postgraduate, and she's a private practitioner at E-Road. Over to you, madam. You can start sharing your screen.
Good morning, one and all. Sir, could you please share the screen for me?
Last time we had our CME with Tiruvannamalai, Karur and all. This time we are having it with Salem. So we are getting familiar with our adjacent societies. It's a boon by webinars.
Just a minute, I'm downloading it. It's a big file. I'm not able to share it like that.
No, I couldn't download it, sir.
No, I haven't downloaded it yet, but I'm yet to download it. Meanwhile, we can take the next questions. In case of consent from mother of pregnant women till 12 weeks, should husband consent be mandatory? All these questions are there in this one itself.
No,
Not necessary.
Consent from the husband. It is a dictum. No consent from husband for MTP. Only the patient can give. Even if we do without the consent of the husband, if he challenges in the court also, he will fail because the law is like that. No need to get consent from the husband.
Okay.
So don't worry about the husband.
ஹஸ்பண்ட கழட்டி விட்டுற சொல்றீங்க.
RCHID to do MTPs பத்தி ஒரு clarity வேண்டியது இருக்கு வித்யா மேம். வித்யா மேம், RCHID to do MTPs. When it is mandatory, when we can go without getting RCHID. For MMA, we have to get, or first trimester, we have to get. We don't have any clarity about it because we are doing.
Yes, ma'am. Actually, no clarity on this. Actually,
Yes.
they are saying up to the 12-week scan, they are asking for the RCHID. So they made it mandatory that before 12 weeks, they have to be registered. But, we can't insist that we can't send them away because we need to give her that abortion care.
Yes.
You can't just send her away for the RCHID. Up to 12 weeks, probably I think we cannot really
If we
insist.
do it without any RCHID, will the law punish us? That's the thing. Will the DD or JD will ask questions? That is the main thing, no, because we will do it anyhow. Whether the department will question us, then we have to talk with the DD and JD
Yes.
to have clarity.
Yes, I think we need to discuss with them.
Safe abortions. Then only
Yes,
we can do the safe abortions.
Because, and many times you will find that all these people will not get an RCHID if they are planning for an abortion. Anyway, we are planning for abortion, why should we go there? They'll think like that.
Yes.
And you're very right. I think if you ask the JD, she will say, you inform us every time when you do something like this. That's what she...
Right. The confidentiality is breached at that time, no?
Yes, and it delays. See,
Yeah,
when
unnecessary delay.
immediately done.
Yes, ma'am.
Sir, click on this enable editing button, sir.
Yeah.
Yes, sir.
So,
Sir,
madam,
go
you can
back.
start.
Sir, just a minute, sir. Can you go back once, sir? Stop sharing the screen, sir, because there will be a few videos in this presentation. So go
Okay.
back and start sharing, sir. At the bottom, you'll have two check-in boxes, which is share sound and optimize for sound clip. You have to check in both the check
No,
boxes,
should I share the videos?
because after this, in the presentation also only you'll have videos, sir. So
After this
if not, if
presentation,
you
there
don't
will be-
share the sound, only video will be play and audio will be muted.
Okay.
Like we can't
So
hear
I
the
should-
audio.
Right now, I should share the video, is it?
So click on the share sound and optimize button, which is there in the bottom left, sir, in the share screen. Then you share the screen.
Okay.
So meantime, Suganya Sendil has asked, is it necessary to fill Form C and Form 1? Cases
No,
of,
ma'am. No,
missed
ma'am.
abortion, there
It's
is
a
no
gynae
need.
case. It's a gynae case. Already we have, she's from Salem or Erode, we have taken a training like that. For
Yeah, that-
ectopic, missed abortion, belated ovum, they are all gynae cases. Don't bring them to MTP register. Don't, you can get consent for any surgical procedure, but Form 1, 2 and all not to be done.
What should I do? I think I lost it. So should I just share the screen or what should I do?
Stop share the screen, sir. Before you click on the share button, if you click on the share screen at that bottom left, you'll have a two check-in boxes, which is the one is optimized for sound, video clip and share sound. You have to click on both the check-ins. Check boxes.
Module 3, I have to download.
Download it, sir.
In the
Yes, sir.
interest of time, why don't you go ahead and do that?
Okay, sir. I'll do it, sir. Okay, then, sir. I'll share the screen, sir.
Yeah, okay, fine.
Sir, can you stop sharing the screen, sir?
Yeah, I'll stop. I have stopped sharing.
Screen is visible, sir?
வீடியோ ஆஃப்ல தான் இருக்கு.
ஷேர் இருக்க மாதிரி அதுல போய் டிரைவ்
Sir, my screen is visible.
Your screen is visible.
Yes, sir, visible.
Vanitha madam, I think you can start.
Sir.
Yeah, yes, you can start.
Good morning, one and all. This is a SAVER module 3. It means that safe abortion, values and evidence, rights or respect. It's a joint FOXI and WHO initiative under Master Trainers Orientation Virtual Program. Next slide, please. This module aims to define respectful abortion care according to WHO standards and to highlight how norms and stigma affect the services and to provide WHO SAVER resources for respectful abortion care. Next. As we all know, the law has been changed. So to spread the new law, we need the association and support from the OB-GYN providers. FOXI is the largest healthcare provider base for abortion care. According to this module, online training is also possible for respectful abortion care so that it can reach all kind of healthcare providers. MMA uptake has been increased, which is early and safe. So patient safety, respect and quality matters more than ever, and we all have a role to play. Next, sir. What is respectful abortion care? It is adapted from respectful maternity care recommended by the WHO. It refers to care that maintains safety, dignity, confidentiality, and ensures freedom from harm and mistreatment, and enables informed choice and continuous support during and after all types of abortion. Next slide. In simpler terms, The respectful care means you as a provider or as a patient treat and are treated with dignity, empathy and compassion regardless of the race, ethnicity, gender, socioeconomic status or reproductive history. If you ever feel that something is not right, speak up. As health professional, it's our duty to listen and support. Communication is the key for all. What are norms and stigma? Next, sir.
Social norms are the unwritten rules of behavior that are considered acceptable in a group or society. Norms can change according to the environment, situation, and/or culture in which they are found. People's behavior may also change accordingly. What are some examples of social norms? In times of COVID-19, there are new social norms that are considered COVID-19 appropriate behaviors like wearing a mask, maintaining social distance, and to wash or sanitize our hands regularly. An example of a social norm that we must follow at all times is to not use profanity in conversation, especially formal or official conversations or when talking to patients, clients. Now let's look at some examples of social norms around gender. Girls wear pink, boys wear blue. This is a gender stereotype. Girls and boys can choose to wear whatever color they like. Color has no gender. Men should be working, strong, and not show emotion. Women should be caring and nurturing and stay at home. Men should work and make money. Women should take care of housework and children. There is no need for women to own or inherit property. Now let's look at a few examples of norms around sexual and reproductive health. Just as norms around gender are smaller aspects of some broader social norms, norms around sexual and reproductive health also trickle down from certain norms around gender. According to the WHO, good sexual and reproductive health implies that people are able to have a satisfying and safe sex life and that they have the capability to reproduce and the freedom to decide if, when, and how often to do so. A woman should be married before getting pregnant and having children. Adolescent sexuality and premarital sex are unacceptable and immoral. Women are responsible for contraception. Now we see what is stigma. Stigma can be understood as a shared understanding that a person, a quality, or circumstance is somehow morally unacceptable. What are examples of sexual and reproductive health stigma? A shared understanding that sex before marriage is morally wrong and/or socially unacceptable. A girl who uses a contraceptive method is promiscuous and will have problems when she decides to get pregnant. A married woman is more deserving of contraceptives than an unmarried woman. A girl who has had an abortion is committing a sin and brings shame to her community. Having an abortion has long-term health effects and the woman's health will never recover to her pre-abortion state. Women who have had an abortion once would become habitual and avoid using contraception. It is important to understand that norms and stigma are different from laws and policies. For example, an unmarried girl seeking abortion is considered immoral due to stigma, whereas, as per law, sex-selective abortion is illegal in India. In this exercise, we explore how social norms and stigma influence access of reproductive health and rights, how people experience SRH stigma, the impact social norms and stigma have on our actions personally and professionally, and the impact they have on the actions of others, personally and professionally.
So the stigma and norms perpetuate disrespect and abuse. The kind of disrespect and abuse are physical abuse, verbal abuse, sexual abuse, and stigma and discrimination, failure to meet professional standards of care, and the poor communication between women and the healthcare provider, and some kind of healthcare systems with a specific condition and constraints and limitations. The right of but every woman has the right to be free from harm and ill treatment. They have the right to get information, to get protection under laws, and to get informed consent, and to refuse and respect for choices and preferences, and to have a dignity and quality of care. They have the right to timely health care and to the highest attainable level of health. They have the liberty, autonomy, and self-determination and freedom from compulsion. Next, sir. The domains of respectful abortion care are being free from harm and mistreatment, maintaining privacy and confidentiality, preserving women's dignity, respecting women's choices, and engaging with effective communication, providing information and seeking informed consent, and to ensure continuous access to healthcare support, and enhancing quality of physical environment and resources, providing equitable abortion care and availability of competent and motivated providers, provision of contraception advice and commodity security, and continuity of healthcare and counseling. It is time to strengthen the implementation. As we see already, one provider is enough for abortions up to 20 weeks, and abortions up to 24 weeks, 2 registered medical practitioners are necessary, and abortions beyond 24 weeks, we need the opinion from the medical board. We have to spread the changes among the healthcare providers and among the women also. And also expands the eligibility, especially young people and the sexual harassment survivors and married. So for 20 to 20, this is a special group people. They are eligible for abortion even up to 24 weeks. And prioritizes the confidentiality and safety. Respect widgets respects. So the healthcare providers, we as a healthcare provider, we need to be mindful of socio-cultural aspects also. It's a guide to avoiding stigmatizing language. The video, please.
How to talk about abortion, a guide to right-based messaging. Abort a child is medically inaccurate as the fetus is not yet a child. Terminate a pregnancy is commonly used. However, some people prefer to avoid this as terminate may have negative connotations for some people. For example, terminator or assassinate. In some contexts, the word abortion can be perceived as negative. In these situations, it may be helpful to avoid the word completely and use termination of pregnancy instead. It is important to be legally accurate, and in India, abortion is legally permitted to the full extent of the law. However, in many parts of the country, the barriers to access may be so great that abortion is considered by many to be illegal due to conflations with other laws. Make sure that you share accurate information about the legal situation and make the circumstances under which abortions are legal clear. See the WHO Global Abortion Policies database for information on the legal status of abortion across the world. Let us look at some stigmatizing words and how to avoid them. Abortionist is a term used by those opposed to abortion. Healthcare provider is usually a more accurate term to use than abortion provider, as most of those providing abortion care also provide other health services. In India, they are also called RMPs or Registered Medical Practitioners. The preferred terms are medically accurate as the embryo or fetus is not a baby. When referring to the tissue examined following a surgical abortion, an appropriate term is products of conception. However, this term is only useful for materials focused on medical details of abortion, as it is not commonly used or understood outside of medical or scientific contexts. Conscientious or moral objector implies that those who do provide abortions are not conscientious individuals, which is incorrect. Refusal to services must be well founded. For example, sex selective abortion in India is illegal. This tends to suggest an act of wrongdoing, placing unwarranted blame on the woman and frames parenthood as punishment. The right to abortion should never be linked to how or why a woman becomes pregnant. Abortion is a woman's right and choice. Consider the classification of pregnancies into the categories unintended, unplanned, unwanted, or mistimed. The classification relies on a framework that assumes that pregnancy is, should be, or even can be a conscious decision. The complexity and possible ambivalence of pregnancy intention, as well as the dynamic nature of childbearing decisions before, during, and even after pregnancy, are not accommodated in these classifications. The suffix "side" denotes killing, which is not appropriate when describing abortion. When referring to sex-selective abortion, it is more accurate to describe the practice in terms of choosing to end the pregnancy based on the predicted sex of the fetus. Make it clear that abortion is about making an informed decision, and avoid the implication that ending a pregnancy is done without careful thought or consideration. The term keep implies a positive outcome, which may not accurately reflect the situation. In addition, it is medically inaccurate to describe the pregnancy as a baby or child. It is more accurate to describe the situation as a pregnant woman choosing to continue with the pregnancy. Late term could refer to any time in the second or third trimester. Instead, if necessary, use terms that indicate the specific trimester or gestation. Use of late may also imply that a woman is late and thus irresponsible in seeking an abortion. For example, there is no gestation limit for birth defects and associated abortions in India as per the recent MTP amendment of 2021. Use of mother, father, parent during a pregnancy is value-laden and assigns roles that the man or woman may not accept. It also implies that the fetus is a child, which is not accurate. Also, under the MTP Amendment 2021, in India, any woman and her partner, married or unmarried, can seek abortion. Abortion is not contraception. Contraception is to prevent a pregnancy, whereas abortion is to terminate a pregnancy. People often seek abortion due to the occurrence of an unintended pregnancy or for health reasons, and there will always be a need for safe and legal abortion. All reproductive choices and care should be available and supported. People should be supported to prevent unintended pregnancies with access to contraception and accurate information. Pro-life implies that those who support legal abortion access are anti-life, which is inaccurate. Instead, use alternative terms to make it clear that you are referring to individuals opposed to anyone having an abortion. Where possible, our language should reflect the fact that we are service providers with a focus on providing rights-based quality healthcare and support. In order to dispel myths about organizations that provide abortion care, it might be useful to avoid business-related language. Multiple and repeat can have negative connotations, such as repeat offenders. Multiple and repeat also imply that each abortion experience for a woman is the same, whereas each abortion is surrounded by a unique set of circumstances. If safe, what is wrong with having multiple abortions? Because abortions happen under a wide range of cultural, legal, and medical circumstances, it is important to be careful about the terms that you use to avoid mixing up terms and creating confusion. Here are a few phrases to be aware of. Illegal abortions are those that do not comply with a country's legal framework but may be safe if performed by a trained provider or when a person has access to high quality medication, information, and support to safely undergo a medical abortion in a safe and licensed place. Remember, abortion is considered safe as per WHO guidelines when the 3 P's provider, place, and process are safe, trained, and certified. Unsafe abortions are performed by providers who are not registered or trained, or in situations where people are unable to safely undergo a medical abortion due to lack of access to high quality medication, information, or support. It is possible to have an unsafe legal abortion. Unwanted pregnancy is a pregnancy that a person decides they do not desire. Unplanned or unintended pregnancies refer to pregnancies that occur when a person is not trying to get pregnant. An unplanned or unintended pregnancy may be either a wanted or unwanted pregnancy. In India, abortion is legal, but sex-selective abortion is illegal. Provider and place need to be safe, trained, and certified.
Next one, sir.
No woman should die due to an unsafe abortion. And when abortion is provided, it should be given in a legal and evidence-based manner with quality, safety, dignity, and respect. WHO has a toolkit on safe abortion values, evidence, and rights, or WHO SEVA, which is a module-based training for doctors, nurses, health providers, program managers, and really anyone to assess our values, address our biases, and learn together to transform our attitudes towards respectful abortion care for anyone who needs it. During the COVID-19 pandemic, we adapted and converted the WHO SEVA toolkit into an innovative, gamified, hybrid version that you can do either in person, online, or as a combination with an expert trainer, or simply by playing one of the standalone games to learn from the comfort of your home. SEVA has 4 modules: Engage, Inform, Explore, and Equip. In the Engage module, participants review recent media stories from the country about gender, unintended pregnancy, the realities of safe and unsafe abortion, and juxtapose these with the global standard definitions. In the Inform module, participants share and discuss background information on SRHR, on safety of legal abortion, contraceptive prevalence, abortion incidence and safety, abortion law and safety, and achieving reproductive rights in the global and regional or local context. In the Explore module, participants will play various games and watch videos relating to gender, safe abortion, preventing unwanted pregnancy, explore social norms and values, and consider how these may be rooted in stigmatizing attitudes or contribute to stigma from a personal perspective. The Equip module is to promote knowledge of, interest in, and further use of WHO guidelines and tools, with a focus on guidelines and tools relevant to contraception, abortion, and post-abortion care, towards the many steps needed for achieving the Sustainable Development Goals, also known as SDGs, building resilient health systems for universal health coverage, or UHC, leaving no one behind. We must remember quality and dignity of care matter as much as saving lives. SEVA is our small step towards SDGs, starting with ensuring safe abortion is provided with values, evidence, and rights or respect.
Next, sir.
I've changed the slide, madam.
These are the self-paced games, the cross the line and personal compass. Next one. The recap questions. Next, sir. According to the WHO, restricting access reduces the number of unsafe abortions. So obviously it's false. Next one. So when is abortion is considered safe? So previous one, sir. The previous slide. When the abortion is considered safe, when the both criteria are met by appropriate methods and appropriate trained persons. Next one, sir. A 30-year-old woman, recently widowed, wants to get an abortion at 22 weeks. As a provider, it is your responsibility to tell her to continue this pregnancy. So as we all know, it's no. She has the right to abort, but it's beyond 20 weeks. So the abortion should be carried out by 2 registered medical practitioners. Next one. In India, abortion is legal. Let us make it safe and respectful. Thank you.
Thank you, madam.
So post-abortion counseling, sir.
Yeah. Can you share this screen or should I share the screen?
Now only you are going to enter the toughest part of profession, counseling.
And post-abortion counseling, yes.
Shriman Kumar, sir.
Yeah, I'll just share.
This one.
Is it visible?
Visible, sir. The third module is pre and post-abortion family planning counseling using the technology for referrals and online consultations. Next, sir. Counseling is a structured interaction in which a person voluntarily receives emotional support and guidance from a trained person in an environment that is conducive to open sharing of thoughts, feelings, and perceptions. The counseling is an integral part of comprehensive abortion services. It is as important as the procedure. Women may need help in decision making. Wherever needed, the spouse should also be counseled. Next, sir. So help women to decide about the termination of pregnancy and help them to choose the method of termination. Ensure delivery of complete information about the procedure. Make them adopt a contraceptive method also. Ensure privacy and confidentiality about the procedure. Be non-judgmental and be sensitive. Establish a rapport between you and the patient. Use simple language and allow the woman to clarify her doubts in her own language. If she has made up her mind for termination of the pregnancy, assess her for the procedure. Next, sir. What is the relevance of peri-abortion family planning counseling? It is the best time to make them accept a contraceptive method. And also, the return of fertility is so quick, and minimum of 6 months of gap is required before next pregnancy because the health benefits and better future pregnancy outcomes. 90% of abortion-related maternal mortality can be prevented by ensuring contraception. When to start pre-abortion family planning counseling? We should start the counseling in the first visit and first consultation itself. What to counsel? The importance of the contraception and the importance of return of fertility within 10 days, and help them with the choices, and the counseling should be method specific. If the woman is not willing for any contraceptive method, do not refuse MTP. Please undergo with MTP and try and counsel her after the procedure. If she is still not willing, call her for follow-up in a week's time and counsel. Sometimes we have to counsel the spouse. It may be helpful to make them adopt a contraceptive method. Assessing the suitability for post-abortion contraception. Previous one, sir. Make sure the abortion process is complete. There's no existing infection. There's no injury to genital organs, and rule out the chances for fresh pregnancy. Then help them to adopt a contraceptive method. Post-procedure counseling has a critical role. It ensures women has understood precautions and care needed during post-abortion period. There's an opportunity to counsel for contraception in case not previously accepted. Reinforces the need for continuing the use of contraceptive method chosen. Next, sir.
This one it's not moving.
The post-procedure counseling procedure continue to ensure privacy and confidentiality as we carried out before the abortion. So reassure her in case of any problems and repeat the information about post-procedure care and danger signs. If they already opted for a family planning method, appreciate them and counsel them about the immediate cares and ongoing methods and follow protocols and continuity of the care and counseling cards. If they have not yet decided about the contraception, allay the anxiety, counsel about the importance of immediate adoption and extended period of adoption, and counsel the couples, and also counsel them about the emergency contraceptive pills. What are the post-abortion contraceptive methods available? The barrier methods are condoms. The condoms can be used as soon as sexual activity is resumed after the first trimester abortion, as well as in the second trimester abortion. They can use as soon as the sexual activity is resumed. There is no hormonal side effects in using the condoms. It can be used without consulting a healthcare provider. It's easily available, easy to use. Prevention against sexually transmitted infections, including HIV. It enables the men to take responsibility of contraception. And also we have to counsel them about the failures. Next. Intrauterine contraceptive devices, which is one of the best and effective and safe methods. IUCD 380A and IUCD 375. It can be inserted immediately or up to 12 days after confirmation of a complete abortion in a MVA. With a medical abortion, that's MMA, it is inserted around day 15 of the process, provided the abortion is completed. In case of second trimester abortions, there is no role for an MMA. It can be inserted immediately or up to 12 days after the procedure is complete, and contraindications are ruled out as the continuous vaginal bleeding or evidence of infections. The additional informations are: it is a highly ineffective method, provides long-term contraceptive for 5 years if it's on 375 or 10 years if it is on 380A. Can be provided by trained doctors or by PPA usually train doctors after second trimester abortions. If there is no interference with sex, immediate return to fertility on removal, there is no hormonal side effects. Next, combined oral contraceptive pills. It can be taken immediately or up to 7 days after abortion using a MVA. In case of MMA, it can be started on day 3 on the day of misoprostol uptake or within day 15 of the process after confirmation of completed abortion. In case of second trimester abortion, it can be used immediately or up to 7 days after the MVA. The additional information are the menstrual cycle will be a regular, can be provided by all healthcare workers, no interference with sex, offer protection against ectopic pregnancy, endometrial and ovarian cancers, and benign diseases such as fibrocystic and fibroadenomatosis, but not suitable for women who are breastfeeding babies less than 6 months old. The hormonal long-term injectables, depot injections. In case of first trimester abortions, it can be injected immediately or up to 7 days of abortion in case of MMA, in case of MVA. In case of medical method, it can be started on day 3 during the misoprostol administration. If a second trimester abortions, it can be injected immediately or within 7 days of MVA. Additional information is highly effective. The confidentiality and privacy is maintained, can be provided by doctors or the healthcare providers like ANMs or nurses. No effect on the quality and quantity of the breast milk. No estrogenic side effects. Offers protection against ectopic pregnancy, ovarian cancer, iron deficiency, anemia, and uterine fibroids. Next, sir. Permanent methods as a female sterilization or vasectomy. The female sterilization can be performed after an abortion in the absence of any infection or severe blood loss concurrently with MVA or up to 7 days. Or with MMA, it can be done only after the first menstrual cycle. Second trimester abortions, mini-lap sterilization can be performed concurrently or up to 7 days after an abortion in the absence of any infection or severe blood loss. Additional information, sir. The permanent method of contraception is highly effective immediately. No interference with sex, no effect on breastfeeding, no long-term side effects. Offers protection against ovarian cancer also. Vasectomy is performed on males independent of the timing and procedure of the abortion. It's a very effective permanent method of contraception. No interference with sex, no long-term health risks. Next, sir. This is a summary. Contraceptive methods with medical methods, that's MMA. We can use COC, that's combined contraceptive pills on day 3, that's during the administration of misoprostol. Injectable contraceptives also can be given on the day 3 during the administration of misoprostol. Centromon, that's the ormeloxifene, also can be given on day 3. IUCDs, during the MMA, IUCDs, the copper teas can be administered on day 15 after ensuring the the uterine cavity is empty. Tubal ligation can be done. Next, sir. Contraceptive methods after MVA, surgical methods. The combined contraceptives and injectable contraceptives and synchromons and IUCDs. All these methods can be used during the procedure or within 7 days. The IUCDs can be administered up to 15 days post-procedure. Make sure the uterine cavity is empty. So that the tubal ligation also can be done concurrently during the MVA or it can be done within 15 days. Next, sir. Next one. So we are using the technology of teleconsultation and telecounseling and teleguidance and telereference and linkage to provide the MTP services. So use the technology in the FAMDO website provides information about the MTP services and counseling about the contraception counseling. The social media like Ask Tanu and YouTube videos are there to provide counseling about the post-abortion or post-delivery contraception counseling, and also about the MTP services available. SWOT of teleconsultation. The strength is it's useful during the COVID era, approachable throughout the process, and it's easy to create awareness and it's easy to spread the awareness. The weakness is face-to-face counseling is not available. So, but we can use the opportunity. And the threat is sometimes people may miss the opportunity and misdiagnosis is there. Next, sir. The key message is, sir, realize the need of post-abortion family planning services, bring the couple on board and strive for 100% coverage, capitalize on the basket and applicability in post-abortion period, and use the technology as far as possible so the scope for entry in comprehensive abortion care services. The adolescent reproductive health needs both online and offline to be addressed. Thank you, Saravana Kumar sir, Nancy ma'am, for giving me the opportunity to take part in this training program. Thank you, Ananda.
Thank you. Thank you, madam. Thank you for the wonderful presentation. I think all of us would have been, both societies would have been benefited out of this RAC program, and probably we will be changing our attitude towards the patients and give them a respectful abortion care. Anything else to be added? Yes, there is a post-test and feedback link is there. You all can download that and then send your feedback for that.
You can send it after the meeting now, sir.
Yes,
not now.
Okay, okay.
After that only we will receive the certificates.
Okay, okay. If there are any doubts, we can clarify. Otherwise, I will go ahead with the vote of thanks.
Sir, these updates should be communicated to the DD family helper, sir. We will
Yes,
also
madam, sure. We will
DD
communicate with the
DD
family helper, and then I probably missed out to invite them also.
Mainly the RCHID program problem. We must get a clear-cut idea up to what weeks we can do it without getting IDs. So we should inform our colleagues.
Okay, we will inform them also. Okay. At the outset, I would like to thank the Foxy WHO combined initiative to give a respect to our abortion care. So it was just an email away where I could just write an email, and then I got all the information, the slides, the link, everything in one go, and it was very easy to communicate with them also. And I congratulate and thank the Erode Obstetric Society, which immediately they gave a consent to share the program with them. And with our President, Dr. Vidya Prabhakar Madam, who gave the nod to go ahead with the program. I thank the speakers, Dr. Nancy Madam, Dr. Prema Priya, and Dr. Vanita Shri. And there are a lot of stalwarts also. Dr. Revati Madam had come, Revati Janigraman Madam, Premlata Madam, Radha Madhav Madam, all of them were also there in our society programs. And I thank Ajay sir also for clarifying most of our doubts and bringing his own inputs and with all his contribution. Thank you, one and all. And I thank our pharma person who made all this one possible. I mean the flyers, Mariappan. Thank you, one and all. Thank you all. Thank you, madam.
Thank you, sir. Thank you, Dr. Saravana Kumar.
Thank you.
You have done a wonderful job and joining Erode and Salem in this thing. Even amidst your Yuva Paksi program, you have taken much efforts to organize this very useful webinar, sir. It is a day-to-day practice problem discussed very well. And thank you for giving opportunity for our members to join this thing. Thank you so much.
Thank you.
Thank you to Vidya ma'am. Vidya ma'am is one of it.
Okay. Thank
we
you.
will meet you in Yuva Paksi, sir, in person.
Okay, madam. And I request all of you, whoever is there, the participant, to join us through the
Yes,
party.
we have shared the link, sir. I already have
Okay.
shared the link for registration. We'll
Okay.
come in a big number, sir.
Okay, thank you, madam.
Thank you, sir. Thank you so much.
Thank you, everyone. Thank you, Dr. Nancy. I was actually busy doing the post.
Yes, ma'am.
Yeah, feedback.
Okay,
So,
ma'am. Thank you, ma'am.
thank you very much. Meet you all in your Foxy.
Yes, ma'am. Sure, ma'am.
We would like to welcome all of you here.
We'll come with a big crowd.
Yes, we need it from you. Erode is our neighbor. You have to be there with us.
Sure, ma'am.
Thank you very much.
Shall we close, sir?
Yes, ma'am.
Thanks.